Tweets are coming in very thick and very fast. I hope Sam Gituku can hear me because there's a lot of questions being asked here. Take a couple of notes here. Mwangagi Wanzi says, currently, I am paying 1,400 shillings with NHIF. With the new SHIF, I will pay 2,178. Do you care for the increased deduction on Kenyans' workers' pay slips? That's the question that Mwangagi is asking. Jeremiah Karaoke says, with deductions of, say, 14K per month for SHIF, comes to 165,000 per annum. That's almost the same amount for many pay for private health insurance. Now, the majority will possibly drop. Thus, such insurances will have to declare their redundancies. Has government thought of such impacts? Also, why is the Ministry of Health doing public participation, yet there is a message that SHIF will be deducted as from January 2024? Baros Wajir says, I have questions to the Cabinet Secretary. 1. What is special in the new health insurance that is going to benefit people with chronic illnesses like diabetes and hypertension to get their medicine? Question 2. What is she doing to curb the shortage of Ventolin? Question 3. When will NCLEX Center be operational? GoDaddy Barazawera says, what use will the SHIF be if our hospitals are understaffed? Medical interns, despite not being adequate, help in ensuring Kenyans have access to quality health services. However, the Ministry of Health has delayed posting of said interns for more than 7 months. A lot of questions, few answers, or maybe we will get some answers. There's Sam Gituku right there, noting down all the questions as we speak. Sam, I know you're ready for this part. Take it away.
Right, thank you so much, Jeff, for those questions. And indeed, they are quite deep. We'll be finding the answers. And of course, we'll also be listening to the live audience that is here at Makina Social Hall. But I think it would be justice to just give the opportunity for Waziri to respond to some of this. For instance, that one that he's talking about, the increment in terms of the contribution they're making and the impact this has on pay slips. And I'm sure, Waziri, you know what the journey has been since January 2023 until now. Of course, after the Finance Act of 2023, a lot of impact in terms of the taxation, but also this, the affordable housing deductions, a question that is now even in form of a bill at the moment. Then Social Health Insurance Fund comes. At the same time, we're dealing with NSSF rates. The second round of review is on and should be starting in the next month or maybe 2. What is your comment about the dwindling power of the payslip?
Thank you, Sam, and to thank whoever has posed that question. One that I would want Kenyans that we ask ourselves is, why is it that the private insurance have thrived so much vis-a-vis the public? Why is it that the private facilities have thrived so much at the expense of public facilities? What is it that makes somebody move looking for services, health services? One, they'll go to a facility, there is no health worker. They'll go to a facility, there is no medicine or commodity. They'll go and find that there is missing even diagnostic or equipment. What are we trying to do with the Social Health Insurance Fund? We want to ensure that if you go to a facility, you should at least find a health worker. If you go to a facility, you should find commodities in that facility, and therefore you don't need to move. If the public insurance is working for all Kenyans, then the need for private insurance will be reduced, so that then it becomes an issue of preference. For example, if I have malaria, I should be able to be treated at the nearest facility here in Makina. But should I choose out of a choice that I do not want to go to Makina dispensary, I want to go to Aga Khan, then I should be able to pay for the whatever that I'll find at Aga Khan. In my case, I call it hospitality. But the best minimum, and that is what we want to assure Kenyans. And for me, I'm really willing to engage in that discussion is, what am I going to ensure that even with these deductions, they are able to get services?
But Waziri, there's something interesting you say there, that once SHF comes on board, the appetite for private medical cover will reduce.
Yes.
But usually this is a benefit that is given to employees by their employer. Very few employers that you find, they do what is called premium recovery. So what are you telling the workers?
What is the need?
The employer
need is because
for
the
that
public
benefit.
Insurance is not adequate. We have seen how the current NHIF does not meet certain aspects. Therefore, there's need for an employer to step in to ensure that the employees are comprehensively covered. If we fill that gap with a public insurance, then the need reduces.
What I'm saying is, employees, including members of parliament, because they have a medical cover.
Yes, they do.
It is the employer that pays for that. Now you're asking the employee to pay for it, and it's affecting their disposable income without a cap.
Where does the employer get that insurance to pay for the employee? They get from the money that would otherwise have gone to the employee?
Not necessarily. It's an additional benefit.
Not necessarily. There's a way the employer will recover that money somehow. There's a cost to it. It cannot be free.
Now,
so can I respond to the others? I think somebody has said that...
We'll get to them.
Okay.
I just want to circulate the question so that we can hear from Mheshimiwa Wanyonyi here. You sit in the Committee of Health in the National Assembly. So, and there's someone here, Jeremiah is asking about raising this premium. And of course, they're saying that when it becomes so expensive, there is the risk of redundancies. As representatives of the people, and you're hearing this sort of feedback, which will also be taking a few comments from the people here, what will you do with it?
I think, Sam, the way Waziri has said, of course, to whom much is given, much is expected. I know the current payments that have been done to NHIF, like Mangak said, he was paying $1,400, but look at the coverage of the cover that he was getting. It was not efficient, it was not effective. And now, under the current arrangement, he's only supposed to increase his contribution to with around, I think around 800, 2,000 or something. But look at what we are going to offer. The cover now is going to be comprehensive, which means then the amount of money that we've been using in terms of providing for healthcare, treating our members of our family, that money is now going to be shifted and directed to something else. And so while it is true that this somehow increase in terms of our contributions, but also the benefits are way beyond even what we are contributing. And I think secondly, Sam, for a very long time, as a country, we've been thinking about ourselves. We've been thinking about my neighbor is on his own. I think it's reaching to a point where, as a country and as a people, we must now start also thinking about our neighbors. We must be a community. That whatever my friend and my neighbor is going through is also my problem. That when my neighbor is a cancer patient is my problem. And how do I also then help my neighbor here? It's not by every week going for fundraisings. Today, Sam, when I show you my phone, I'm almost in 100 WhatsApp groups. And it's even worse because at home I'm called investor. And so people think I have a lot of money. So the support that is required from me is beyond even my constraints. So I think really, for me, we are reaching to a point where we must also be responsible and cultivate in us that sense of citizenry. And also really contribute. Those of us who are earning more, contribute more. So that we can carry this our friends who are down here along in terms of accessing healthcare like any other person.
Okay, I hear you. I want us to take a look at what the Kenyans are saying here in the audience. We start with the lady back there. If you can tell us your name and what your question is and to whom you're addressing it to. You can use whatever language, Kiswahili ama Kiingereza.
Good evening, everyone. Yangu inaenda kwa CS. Kwanza kabisa, Madam Nana, uko na bahati sana kwa sababu NHIF ilikulipia kansa mpaka dakika ya mwisho. My name is Neema Ibrahim. I was born and raised here in Kibra. Dada yangu mkubwa ako na breast cancer. Na tukijua ilikuwa ni stage 4. Tukienda hospitali, unajua hatukukuwa tunajua hizo stages za cancer na everything. But kufika hospitali, tulilia cause first thing tunaambiwa anafaa kwenda chemo of which ni 53,000 per session. Na hiyo 53,000 per session, NHIF haikuwa ina cover. Kwanza walisema NHIF haikavi anything. So tukajaribu vile tuliweza mpaka pale tulifika. Ukienda kuna specific hospitals zenye zinadili na mambo na cancer. Leo ukienda hiyo mashini inafanya kazi, utalipa hiyo 53,000. Kesho ukienda upate hiyo mashini haifanyi kazi, utalipa 63,000. Bado hujapima damu, of which ni almost karibu 15 to 20,000. Kuna hiyo 63,000 ya kimo. Kuna, yani matibabu ni nyingi na dawa zake pia ni expensive. So swali yangu ni je, sisi walala hoi, cause mimi nikizaliwa nilibelieve cancer ni ya masonko. Sasa hii naona hata sisi walala hoi inatu affect. Na tuliambia ni hustlers nation. Tunaumia kwa sababu gani? Haitusaidii pali yoyote. NHIF inakuambia we are not covering for cancer, we will cover for something else. Ukijaribu kuongea unashindwa. Daktari mpaka wale kuna social workers wenye kwa hizo department kwa hospitali wanakuambia ingekuwa ugonjwa mwingine ni sawa but cancer no. Sijui mtatusaidiaje cause tunaumia.
Okay.
Yes.
All right. Swali moja hapo. Another question here from the gentleman in white t-shirt.
Thank you so much. My name is Colin Sonyango. My question is directed to the CS. I have two of them. I believe humans live in an independent, interdependent lifestyle. So I believe the rich should be compassionate enough to at least work with the poor. And in this way, it's not only that when they need the poor, that's when they think they should be compassionate. Mm-hmm. So the first question, I've heard all that, the calculations and everything, but I think why should someone that is unemployed pay 1,000 shillings to SHIF when someone who's employed earning 20,000 pays 550 shillings per month? I think that's a bit not reasonable or not logical. Also, the second question is, I think the SHIF policies and the rules that I've seen there, they are good. They are good if well done or presented. Mm-hmm. But how is the ministry going to ensure that there is no mismanagement of these funds, because the rich would be compassionate enough if it could be 2.75% or less, but they could be compassionate enough to give that money. But how is this money going to be ensured that it's not mismanaged, okay, or corrupt dealings are going through or handled there?
Okay, all right. I think let's handle those two. And if any of you would want to dive in, you may. Waziri, they were specifically directed to you. Your short answers?
For those ones here or even the prior ones?
No, you can combine all of them.
All of them. There is a viewer who said, why are we saying we are going into regulations, yet the deductions are beginning in January? That's not true. That is one of the misinformation that is being moved around. Deductions will only begin after we have finalized with the regulations. Public participation has been done. We have gone to the Committee on Delegated Legislation, and the Attorney General has given us a go-ahead. We will gazette the regulations. That is when deductions will begin. Our projection, because we know many Kenyans are suffering and would like to benefit from this cover, we project at least to be up and running by 1st of March. If we are able to do it earlier than that, the better for Kenyans. About cover for chronic illness, yes, within the Act, we have the Emergency, Critical and Chronic Illness Fund. And that is to mean if you go through the level of services that you maybe discovered at primary level, you move to the secondary, your cover was exhausted, there is the Critical, Chronic and Illness Fund that will kick in to take care of you. What are these chronic illnesses? And Mami, that answers, Ma'am, your question on cancer, that now we have a fund that should be able to take care of patients who have cancer, whether it's going to be chemotherapy, whether it's going to be radiotherapy, whether it's going to be surgery. Whatever treatment that is required will be covered by this fund. There's a question on out of stock of Ventolin. Ventolin is a brand. It may be out of stock, but there are alternatives. Salbutamol. Ventolin is the one from the original company called GlaxoSmithKline. But within time, we have had many generic brands that have come of good quality. They are available within the market. And even us at KEMSA, Salbutamol is available.
For the viewer who doesn't understand what that treats?
It treats asthma. I think that is the question that the viewer asked. Ventolin is the one that you see a can like they puff when they're blocked, so that then it unblocks them. Right. So you may not get the one written Ventolin, but we have the alternatives that are available. NCLEX Center, we just opened it a week ago. And now Pearson VU, the one that is, this is for an exam center for nurses who want to go and practice abroad. Initially, in Africa, it was only in South Africa. So anyone who needed to go and work in the US a nurse, they needed to travel to South Africa to take this NCLEX exam before then they can travel to the US to work. Now we have brought it into Kenya. It is in Westlands. Operations have begun, and the first cohort will be doing their exams in March. Right. So they can now access exams here. There was a question on interns, why the delay in posting. Posting interns is not an administrative thing, that you'll just wake up and post interns. One, we have interns, a cohort that is already in session. We have internship centers. Not all hospitals, not all facilities can accommodate interns. Interns need to work under supervision of a practitioner who is already licensed to practice. We must have enough practitioners. We must have enough centers. We must have facilities that they can go to practice in. So we already have a cohort that is there. We had a meeting on Monday with the unions, and we did explain to them that once this cohort exits, the one that is already within the facilities, then we shall post the next interns. Now on staffing, one of the things that we are doing under universal health coverage, which is one of our pillars, is human resource for health. We already did a survey in August of last year to look at what is the level of service. We did an assessment. Right. So we know the numbers that are there. We know the gaps that we have. And the governor seated here will tell you that out of their healthcare budget, almost 80% goes to health workers. So now we have to see how is it that then we manage this? Because besides the health worker, you need other items. But we have a plan to see then how do we fill in the gaps, having taken care of the budget. Collins, the question of 1,000 paying, the unemployed paying 1,000, the employed paying 500. That is why we are introducing equity, 2.75% of income. It doesn't matter where you have earned your income from, whether you are unemployed, you are in informal employment, or informal employment, whether ni jua kali, whatever income you are making, 2.75% of that income with a minimum of 300 bob. You raised a very valid question, Collins, on management of funds. We have had a big issue with leakage of revenue. We have had cases where in the NHIF, one patient has been amputated, the left leg at the same spot at the knee, twice or 3 times. What does that tell you? That is fraud. We have had cases, and the governor brought it out very well, where a cesarean section in a public is being reimbursed at maybe 10,000, but you go to a private, somebody is charging for that cesarean at 200,000. Those are the inequalities that we want to take care of. What have we done? We now have a digital system. We are working on deployment that as we begin with this SHA, we are putting in digitization. Social Health Authority is largely a digitized system. Identification of registering beneficiaries, identifying beneficiaries, verifying claims, all those are digital systems up to the time for payment. So we are infusing in digitization to ensure that we reduce on human interruptions and any exaggerations that there may be. We have even facilities that have been luring patients who do not really need the surgery. I know of a facility I do not want to name, but it goes around looking for anyone with an NHIF card. And because you are old, they assume that you have a knee problem. They all pick people in a van, take them to a hospital, take them through surgery, then get money from NHIF. That is immoral. And those are some of the things that we want to stem that are happening at NHIF. So we have put in place a mechanism to manage resources. From where I sit, I have the confidence in the system that we are putting in place, that we have ring-fenced all revenue leakages that there may be. But again, we have the FIF, that even at different service level points, funds are ring-fenced and reintroduced back into the health system. Thank you.
All right, I'll get to you, governors, but Nana, and also we'll be taking a question from someone who will speak to us in sign language. We have a way of decoding that or translating. But Nana, talk to us about, so when you're going through your treatment and you're using NHIF, what are these facilities that you are going to?
I was actually going to Kenyatta University Referral Hospital. That is where I was treated. It's a public hospital. But also in that process, of course, there were problems here and here. And these problems, so many cancer patients are facing them. One of them being that there's something called blood works, as Madam CS has said, that you have to pay. NHIF doesn't cover that, and it is a huge problem. I'm telling you for free.
So did you choose to go to KU Hospital?
Yes. I chose to go there because, you know, cancer is expensive. I'm telling you the truth, you don't just get cancer and start up there. You have to trust the system with our government, because now let me tell you the problem that we face. I, being one of them, what I faced. The blood works. It is very expensive, and you have to do the blood works before you do the chemotherapy. Right. Number two, there's something called CT scans. There are a couple of scans that you have to do before you start your treatment, and in between the treatment also. And you find out that NHIF pays for half, and then you are told to top up. Seriously, these patients, they are so oppressed financially. Where do you expect them to get money from? Then another problem is, of course, drugs. Like currently, I have a lady in Dadora. Our drugs for hormone therapy costed 109,000. NHIF covered 100,000. Up to date, 6 weeks down the line, that family hasn't been able to raise the 9,000. What is happening to that patient? Probably, that patient, she will 100% get the recurrence of cancer. Right. Another problem is the, what do we call them? Of course, drugs and PET scan. You find out that you've done chemotherapy, you finished, you have to do a PET scan, because the doctor is thinking that this thing is not working. So you have to do PET scan twice a year. NHIF only covers for one PET scan once a year. So then it becomes a problem. And these nitty-gritties, what happens? Most of the cancer patients and their families, they give up, they look at these people, they die because they have no options.
Okay, Governor Sang, tell me, because she chose to go to a public hospital because partly it is a good hospital, but also because it is more affordable. I just wonder, in Nandi, how many hospitals can treat cancer? Because sometimes people go to the private facilities because that's where they can access certain service. So even if you have more resources, how do you make this service accessible?
In Nandi currently, we have only Kapsabet County Referral Hospital that is offering, treatment for cancer, and that is only chemotherapy. In terms of the other forms of treatment, that we have to go all the way to, Moi Teaching and Referral. The others, private facilities do not have. So basically for us really, and this is a service that started almost, I think, 2.5 years ago, we started providing that service. So basically, part of what this process is supposed to do, this entire reform package within the health sector, is also to provide more centers. We are hoping that with implementation of this program, it shouldn't just be, Kapsabet County Referral Hospital. It should happen in all the other sub-county hospitals so that then that is available. So I think for us, we are looking at this journey as a way of ensuring, because I think there has been a lot of discussion just about the, the deduction and the amount, but you have to look at it. And some of us within the Council of Governors would have had difficulty with the Ministry of Health if they came with just one-sided or, a part solution to the entire process. But that you are providing an holistic, reform starting from primary. You had the lady mention that the sister was diagnosed at stage 4. What is really the problem? Is that, the facilities may not have been available for them to, to do the test ahead of time, so that then you can be able to have, preventive and promotive health. This process of implementation of the reform agenda under health starts, by taking us to where we are supposed to be. Okay. And I can tell you, Sam, if seated as a governor when I went into Nandi as governor the first time, I had a lot of this set of issues to address. Primary health care would not appear as crucial to me at that point than creative, because I have patients that are lining up in the hospital. I have to deal with the patients, and therefore you work with increasing the human resource, you work on increasing the budget on medical supplies and the likes. But the truth is, you are then investing resources and waiting for patients to come. I am happy with the process that we are now doing, where we are focusing on primary health, that then we are starting at that level. For example, pressure, high blood pressure. Many people discover that they have high blood pressure when they are treating something else. You have a tooth problem or you have something else, and you go to the triage at the hospital and you are told, by the way, forget about the tooth problem you are talking about. You have a major problem here with hypertension. So I think the fact that we have CHPs now going to the communities and engaging the communities at that level, this process or this reform agenda by the ministry and by the national government together with county government has started at the right place. Okay. That we are looking from primary health, then moving to to the other stages, as it were. Okay. So I think for me, this reform agenda, and the minister should then look at how to expedite the process, because I think also this whole transition could run into a problem.
All right. Of course, the NHIF has until November 21st, I think, for the transition, which is 1 year. We have a question here from one of the members of the audience. Maybe we can take it. We need to get a mic here for someone to speak in, to translate the sign language.
Good evening to you all. My name is Aska. I'm from an organization called Federation of Deaf Women Empowerment Network, Kenya. So I'm a survivor of cervical cancer. So my question is based for the CS. I have a few questions I'd like to ask you. So please give me time. The first question will be focusing on the community health volunteers. So I'm wondering, the CHVs, do they have skills to communicate with people like me? For example, I'm asking because I've experienced last year, one approached me, they came to my house, they were giving something, I don't know if it was something for cholera, I don't really understand. So I feared because they were giving me something to take and I wasn't sure what it was. And I told her, you have to take it first before I take it. and they took it. And then after I saw it wasn't poison, then I accepted to take it. So communication is key. Communication is very important. We need to strategize on how we can work with the deaf community. The second question would be about the insurance. So 90% of deaf people in Kenya currently are unemployed. They don't have work. They belong to the vulnerable group. So I'm wondering, yes, we have a solution. What strategy are you planning to use to make sure that you are not leaving us behind? Because many times we are not reached, we are left behind because information is not reaching us. We don't get information at all. And my third question would be, I want to ask about the adolescents. So we had HPV rollouts, vaccines. I don't know if it's still continuing till date. And if it's continuing, then again, what mechanism are you making sure to involve the adolescent deaf girl? How are you reaching them and ensuring they're getting the HPV vaccines like everybody else? Thank you.
Thank you, Sam. And so somebody's interpreting.
Yes, she will.
Okay, good. So thank you for the question about the skill of the CHP. One is that we have trained these CHPs to handle the small ailments that would be within the community. But the beauty about it is that a CHP is not picked from somewhere. They are from the community that they live in. So a CHP would know that their next door neighbor has this disability, and therefore they know how they have been communicating. For example, they are neighbors. So that CHP knows. If we were picking CHPs and transporting them, or if a CHP was being moved from one community to go and serve another community, then they would not know the unique needs of each household. But we have given them households where they live in for them to know what are the unique needs of each household. So there are different types of disabilities. It is expected that this CHP understands the household under them, whatever it is that is unique that they need, and therefore they should be able to communicate or get somebody who can communicate when providing the service. The unreached Kenyans, that is what we want to cure with this, that very few Kenyans have been accessing NHIF. We now want to reach everyone. Now, there are those who amongst us in the community have severe disability. They have no capacity or ability to pay. The government is going to pay for them. Once the government identifies that you are an indigent, you have no capacity to pay, you have no income, or you are living with a disability in such a way that you cannot engage in some meaningful activity to earn you some form of income, then the government is going to pay. We have an exercise to identify. And remember, not just us, but we also have the Ministry of Labor and Social Protection. They have a mechanism of identifying these people so that then government can provide support to them. About the HPV vaccine, and thank you for that, this month, January, is when we celebrate cervical cancer, and HPV vaccine is meant to prevent adolescents. We give it to children from, not children, girls from the age of 9 up to 15 years. Ideally, any girl who we know that has not been, or is assumed not to have been starting to be sexually active, then they are given this vaccine. But I want to encourage Kenyans that there's the old adage saying that prevention is better than cure. This HPV vaccine, we are giving it free of charge in schools. You only need 2 doses, 3 months apart, and we are giving it free of charge. This free of charge vaccine, if you get it, then you are unlikely to get cervical cancer in future. If you get cervical cancer at stage 1, you will need at least 300,000 shillings. If you are discovered at stage 3, 4, 5, you must be ready with at least 1 million shillings. And that is why we are saying that as a ministry, we are now focusing on the primary health so that, one, we prevent through giving the vaccine. And I want to encourage girls and mothers, parents, please, if you have a girl who is between the age of 9 to 15, please give them this vaccine free of charge. We have it in school. We have adequate doses with us at KEMSA, and we are going to give them. If we don't prevent, then it is a cost. And that is what eventually feeds into how much each Kenyan pays for their services. And I want to revisit the question that you said that parliamentarians, their employer is paid. Who is the employer of parliamentarians? It's Kenyans. It's taxpayers' money. So you cannot say that it's a benefit. Somebody is taking care of that cost. And in this case, for parliamentarians who enjoy comprehensive cover, it is paid for by Kenyans, taxpayers' money. Thank you.
Interesting. Now, I want us to start winding up, and let me begin with you, Governor Muthomi Njuki, because we are told of the tariffs that claims will be paid based on tariffs. And obviously, treating malaria at a private hospital is not the same as at a public facility, depending also on the levels. So this social health insurance fund, how does it work across the two categories, private versus public?
Well, first and foremost, Kenyans must be willing to take advantage of the numbers. Before I answer your question, we are now getting close to almost 50 million Kenyans, after which in public sector we only about 3,000 that are working. The rest may not be in formal employment. 3 million. And therefore,
that is the formal employment. I mean, there are so many people that are working.
Yes, I'm talking about the public sector.
Yeah.
Basically, that's what I said. Of course, the informal employment is there. But if all of us were to contribute, it means we would be able to take care of the 25% or so that are vulnerable, that may not be able to pay at the moment. And all these problems will reduce. Coming to your particular question, with what you're struggling at the moment, all these issues about the social insurance fund vis-a-vis the NHF, it's all about financing health, which is a very expensive affair, right, especially when we come to the curative level. And I have talked about the financing that is available, or the options that are available in the public sector vis-a-vis the private sector. And in the private sector, in the public sector, where we are finding ourselves giving services that the public feels that they get better services in the private, it's not because we do not have quality. It is a fact that the private sector usually has the allocation, or rather the costing, that gives them a little bit more of leverage in how much they can be able to charge to people. And therefore, they always have the availability of both human resource, they have the commodities, they have the screening, always available. Look at the private sector, the public sector we are talking about, that we are in at the moment. And I know you want to know how is it that we going to make sure that we standardize this time. We agree that we are a little bit far compared to the private sector in terms of the quality we can be able to provide, and that's a gap we want to be able to bridge. First, the first collaboration that we are doing with both the ministry and the counties is to ensure that we have diagnostic equipments that are top-notch, that you can be able to find in the private sector. Even in most cases, better quality, and it's happening at the moment, which of course started with the MES equipment that we want even now to upscale and make them better. That way, we do not have to have our people going to the private sector because of the diagnostic machines. The other issue is the human resource. You will find that most of the time, the public sector is constrained. If in a hospital that has got 2 nurses, you go to the private one, they have 3 or 4. Of course, they end up paying for the good reason that we are churning out more than we can be able to employ. And instead of staying home, they take what is available. We, as government, must pump more resources in ensuring that in the upper cadre, especially in the specialized cadre of doctors, that we have more available doctors who can be able to take care of our people. And they do not have always have to, our patients don't have to find their way to the private sector all the time.
How do you do that?
Well, it's very simple. At the moment, we have a system where after you practice for 3 years, you go back for postgraduates in specialization. The issue, which we have been having a discussion here with the CS, is that the counties or the facilities that usually man the counties have to pay for those doctors when they're on leave, full salary. The ministry at that time is paying their fee. In the meantime, you have a gap in the hospital, which you are not able to fill because you are paying the salary of that person on leave. And we asked in the ministry, it is a high time they took up that responsibility of making sure that they pay for the not just for the fee, but also for that doctor who is away, so that the county government can be able to employ in the short term to replace that doctor who is away. And that will not be having the shortages that we are having at the moment.
Okay.
And also, you have seen these less strikes nowadays by health workers in both the clinic officers, the doctors, because we have continuously been able to meet their demands in terms of what we call collective bargaining agreements. And of course, it's evident at the moment. That means the counties are spending more money in taking care of human resource than it were before. And that way, we'll be able to bridge the gap between the private and the public sector.
All right. Of course, there's so much that we'd have to cover when you're talking about the regulations. Governor, there's something you want to say about that?
Yeah, two points. In terms of paying for doctors who are on study leave, we also appreciate that most of these doctors, like, for example, most of my doctors are either at Kenyatta or at Moi Teaching and Referral for their postgraduate studies. They're actually working in those facilities. I think we must also have some bit of an understanding with these facilities where they are studying and providing services, that the cost should be, their salaries should be either on the Ministry of Health or in the facility where they are studying and providing services. Because for postgraduate studies, they are not just in class, they are actually actively, attending to patients in those facilities.
Right.
So we should be able to give reprieve to counties who can even engage some, doctors, even if it is on contract, as these, other doctors are on study leave. But secondly, part of what we hope that this whole reform agenda also under health is going to provide is standardization of quality of service. As we speak right now, you will hear that this facility is level 3, this facility is level 2, this facility is level 5. But if you look at, there is always requirements to meet for you to meet, to be, for a facility to be graded or rated as level 3 or level 4. But as we speak right now, that entire system is broken. We hope that we can be able to have an organized healthcare system where we all agree that at level 2, what should a dispensary have? In terms of facilities, in terms of equipment, in terms of human resource. Again, sometimes we speak and we think that private facilities are more equipped than public facilities. That is partly true. In the big hospitals here in the cities and the big towns, that could be true. But do you know that there are mushrooming clinics in villages that actually they lack the basics? But since, they invest in a lot of these optics, you have a very good desk, you have very good, publicity around the facility, and you think that they actually have, quality service. The truth is, you could be dealing with healthcare work, human resource that are not qualified. You could be dealing with equipment that are not. So we hope that this whole process.
But should they operate if they are using human resources that are not qualified?
That is why I'm saying that, this, for the first time, this entire reform agenda within the health sector will bring together, like the PCNs. We have healthcare, public healthcare facilities, together with, private healthcare facilities, coming down to sit together and agree. So if we have that standardization process, we should be able to agree on how to rate all facilities so that every healthcare facility, whether public or private, if you are at level 3, you must meet the standards. If you are at level 4, you must be able to provide the services that are supposed to be provided at that level.
Allow me to say something about the funny clinics that the governor has talked about. In August, when we were doing the level of service assessment, we had about 2,000 facilities that closed their doors. Inspectors would not get in. And it's obvious. Why did they close? because they know they are running, and probably they do not have the licenses for running, they do not have qualified health workers, or they do not have equipment. So I also want to tell Kenyans, if you see a facility that even looks suspicious, please let the ministry know. We are the regulators. We have Kenya Medical Practitioner and Dentist Council that regulates all this people. But we have funny Kenyans who would want to set up something just for business, for the sake of it,
was it those
without meeting
facilities
standards.
that shut their doors so
Yes.
that the inspectors may not go in, are they registered?
They were registered. But you see, there are people who would even hire equipment for the purpose of an inspection. Once the inspection team leaves, they go back to their default setting that they don't have equipment, they don't have
And
staff.
the government didn't know this up until now?
There are those who are operating, and you see, the government is limited also. We do not have inspectors all over. But for these ones that we found out that closed the doors, we already started taking action against them, then the regulator should go in and close those facilities permanently.
Okay, Waziri, I just wanted us to tie up matters here because many senior government officials, when they fall ill, most likely they would go to a private facility in the city. You know them. What is the place of these facilities, the private health facilities, in light of Social Health Insurance Fund? And I'm asking that because you find patients getting admitted there, and the contribution of NHIF has been very minimal, whether it's paying for bed or whatever it is. So what is the place of SHIF in this?
One, let me say that SHA, the Social Health Authority, with the fund of SHIF now, Social Health Insurance Fund, we have what I want to call a base cover that is available to all Kenyans. And you can access it, be it in a public facility, a private facility, or a faith-based facility. We have costed our services. So we know for sure that malaria will be this much, X amount. For the sake of argument, let me say 500 shillings. So Social Health Insurance Fund is going to pay for malaria 500 shillings regardless of where you are. Whether you are accessing a public facility, a faith-based facility, or a private facility. As a Kenyan, if you choose to go to a private facility that charges beyond the 500, the social health insurance will pay the 500 that is meant to pay for you. Then for you, the other comfort that you look for, you top up, or your private insurance then kicks in. Okay. Let me also clarify that employers are at liberty to get additional insurance for their staff if they so wish. But what we want to ensure is that at least all Kenyans have access to a comprehensive base cover. So if you feel you want to enhance as a private entity, that is up to you. We will not stop you. But we will ensure that all Kenyans can access the base cover that we have put in place.
When do you see the contribution starting?
Once we are through with the regulations, we go through the process. We have advertised. The next 2 weeks, we shall start going round. You know, there's what is the prescribed in law as to how long public participation should take, a minimum of 14 days. We are going to go through the whole spectrum of the 14 days, sit down, receive feedback, go to Parliament, to the Delegated Legislation Committee, come back to AG, and then myself to do the gazettement. Our projection as a ministry is that by 1st of March, we should be able to start registration of everybody into Social Health Authority. If we are able to finish earlier, we will start earlier.
So registration 1st of March?
Yes, that's our projection for now. But I hear Governor here has said, maybe we start early.
Registration 1st of March. Contribution?
Yes. Same month, March.
You'll have done means testing for everyone in the country?
Yes.
What are you using?
We have a means testing algorithm, which has already been developed for the last 1 year. That is what we have been working on. So that is what we shall be using. And remember, we have a number of experts that we have also engaged. We have received support from World Health Organization to develop the mean testing criteria. And mean testing is not unique to Ministry of Health. Remember, we now have the Open University and the means testing for Ministry of Education. It is the same. Once a household has been subjected to means testing, we already know the level of income. So it doesn't mean that we are really starting from scratch.
Okay. All right. Unfortunately, we have to leave it at that because it's almost tomorrow. Ladies and gentlemen, thank you so much for making time for us. And of course, our great audiences. Unfortunately, we don't have any more time for the questions, but thank you so much. Maybe we can end it as we clap for everyone here who has done a good job thank you, in paying attention to the conversation. Now, Jeff is still in studio. Jeff, over to you.
Yes, I am, Sam. Thank you so much for an amazing conversation there with Madam CS, the governors, and all the stakeholders, and also the folks in Kibra. I hope they've learned a lot, as we have here in the studios. It's been an amazing conversation. The feedback, folks, so much feedback coming in very thick and very fast. Thanks so much, Sam. Get home safe. We'll talk to you later on. In the meantime, tweets coming in thick and fast. Miriam Makeba Mutua. Oh, Miriam Makeba. She says, just one request for the CS and the Kenyan government. Please make cancer treatment free in Kenya. We are losing so many lives due to the lack of funds for treatment. Having lost my own mother to cancer, I know how draining it is, both financially and emotionally. And the thousands, tens of thousands of Kenyans who are of the same opinion. Moses Adieri says, employ more healthcare personnel, otherwise SHIF is dead on arrival, considering that the number of seeking services will be huge. Okay. And Jeremiah Karioki says, good to hear that there are people who benefited well from NHIF. When I needed it most, hospitals said they couldn't touch the NHIF card. I hope SHIF is not going to fall in the same problem of not or delaying payment to hospitals for services delivered. Thanks so much for